ever. So a lot of people have that connotation between lean, and when they hear the word waste, they're wondering, is that extra staff members that we don't need? And that is not the case. We're looking at the processes, how to improve the efficiency and the effectiveness of the processes with the patient at the center. So it's a methodology of improvement and a way of thinking with the ability to transform a culture, and has a long evidence-based history. It helps us create a common language for improvement. So you're going to hear some words today that you're maybe not familiar with, but as the years progress, we will become more and more familiar with them, such as value stream map, A3. So if you ever aren't sure of what we're talking about, please do stop us and we will explain. And the cornerstone of lean is that improvements are identified by those doing the work via a simple formula. And it's to liberate the people who do the work, aka the frontline staff, to make the improvements. So we all know that current change processes of management coming up with, well, maybe we could try this, and throwing it at the staff. That's not how we create engagement or buy-in. That's not how we create an engaged culture. So the work is at the front lines if an improvement starts at the front lines. The changes that are discussed or come up with come from the frontline staff, not from management or senior leadership or anyone else. So it's those who are directly involved in the work. So the way that Toyota implemented this several years ago is that they concentrated on 2 pillars, and that was continuous improvement and respect for people. So much like what we were trying to do here, lean is a culture change and the way that we approach our improvement processes. So our ability and willingness to continuously face improvement with creativity and curiosity and bravery. We're not going to run for the hills when we have a big project. We're here and we're all on board with continuously improving processes. And change is the new constant. So, and then the other thing that I really want to hit home on is respect for people. When we have something that we notice in the trends in the data, let's say sepsis for instance, we really want to go to Gemba and we want to come to the frontline staff and come to you all for the improvement work and build that trust and build the respect, and not be changing processes without having all the key players at the table. So it really is about building the relationships, building the trust between our staff, all of our departments, and working together as a cohesive team to improve processes. So there's this quote from the CEO of Toyota, and I'm going to go ahead and read it. So there's no genius in our company. We do what we believe is right, trying every day to improve every bit and piece. But when 70 years of very small improvements accumulate, they become a revolution. So we don't want to go to a frontline staff member and say, fix ED throughput, because that involves the entire hospital basically, and it's huge, and not one person can change it. So what Lean does and what it teaches us is that we have to take this big process and we have to break it down into smaller pieces and work on one small change at a time. Then when we add all those changes up, we're going to see large improvements. Our goal, again, is to liberate the people who do the work and give them the tools and the right environment to be successful. So the tool is Lean, the Lean training that you're going to hear about today and all the processes that we're improving. And the environment is, again, changing the culture and creating a supportive environment from top down, bottom up, every which way in between. And our outcomes as we work towards our goal in our strategic plan and working on changing our culture and going on this Lean journey together, we hope to have happier employees, happier patients, an increased capacity for work, and a lower operating cost. So the basic steps of the Lean process include, and we'll dive into these in the next slides, and you'll hear more about them in the presentations today. They'll take you step by step through the process. But it includes observation, the value stream map or the current state of your process. You collect data you then pick a storm cloud, which a storm cloud just means it's like a frustration within the process. And then you take that storm cloud and you imagine the future state. What do I want this to look like? What could this look like that would be better than what it is now? You develop an implementation plan, the steps that you're going to take to get to your future state or your ideal state. And then you test and follow up. So test means testing at small scale. So if you have a change, you test it with one person or one shift. And then if you take their feedback, like this didn't work, you change the process, then you test again. That's how quality improvement is intended to be utilized. And then as you firm up that process and ensure that it's working for everyone, you spread the change to all departments, the entire organization. It just depends on what your project is regarding. So the first step, the power of observation. In the past with quality improvement, sometimes we have a knee-jerk reaction to just slap a Band-Aid, do a Band-Aid fix, say we have X, Y, and Z issue, and here's what we're going to do to improve it. And after a while, we just have a process that has a bunch of Band-Aids on it, and it's really not functioning. So the goal of Lean is to truly observe the process and the way that it's being done. Not the way that we think we're doing it in our head, or the way that it should look on paper, like with a protocol. If we know the steps that are supposed to happen, but are we actually doing them? So if you see people up observing your process, they should introduce themselves, of course, and tell you what they're doing. But they're simply writing down the steps as they see them. And then they will come and discuss those with you and say, here's what I saw happen. And you might think like, oh, I've done that a million times. Did I really do it like that? So it's just truly observing the process. Then you're going to take those steps in the process and you're going to map them out on what's called a value stream map. Then we do some data collection. We measure the process and the time that it takes to complete each step in the process, as well as the time between each step in the process, to see if there's any time waste that we could cut down on or focus in on, and could be a storm cloud even. So then we map out the storm cloud, so you have the process mapped out in the steps, and then you draw the storm clouds to the process, and then you pick one. So, and we don't just encourage you willy-nilly picking one. We encourage you to pick one that's going to have enough effect that if you fix this part of the process, it might fix these other storm clouds as well. So we kind of help you work through that as well. And then you do what's called an A3 on them. A3 doesn't stand for anything, it's just the size of paper that you write your information on. The A3 goes over, you do an issue statement, background of the problem, of just that storm cloud within that big process. You do the current state, what does this storm cloud look like? You do a future state, what do I want this storm cloud to look like, so that it's better in the future. And then you develop an implementation plan. So it's the actions that you're going to take to get from here to there. And you can use a 5 why analysis, it's called, that you ask the question, why is this happening? And you don't have to do it 5 times, it's just as many times as it takes to get to an actionable item that you can then say, here's what's an issue with the process, here's what we're going to do to actually fix it. Then you do your implementation plan, you do a cost-benefit analysis, and then you roll it out. You roll out your implementation plan, complete all of your steps, test it like I discussed before, and then the follow-up is one of the most important pieces that sometimes we tend to forget about, and that's to ensure that the new process has become standard of work and that we're not falling back into our old ways and old habits. So generally in the follow-up phase, you audit the process a handful of times, and you just ensure that, for the most part, that this has become our standard of work. Any questions? Felt like I was a little all over the place for a second, but okay.
So is that available to all of us?
It can be.
Do you have it
Certainly.
written down?
Well, no, you were going pretty fast because you have to, and I missed some of the.
Sure,
so
sure. We can send it out.
You could just share it with me.
Sure, I could share it with you as well. Definitely. Okay, so we're gonna start with, we had a little bit of a schedule change, but we're gonna start with,
Is Mel gonna go first? I can go after.
start with,
You were first.
I wasn't.
no, Clay was
Are you were
first.
first? Oh, so I am first.
Hey,
Hi.
how's that?
Well, pretty sore. Really good.
It's just a non-judgment. The back is open. It's fine.
So Clay was gracious enough to trade spots with me because I have a commitment at 12. So I'm Carrie. I work in administration and I was fortunate enough to go through the first lean training that we started back in the fall, maybe? So interestingly, we had a group that was already working on medical imaging access. Just trying to improve that for patients, get patients in more expeditiously so they weren't waiting quite so long for biopsies and procedures. But we were really looking at everything, CT, MRI, special procedures. So when I took the lean training, I decided to kind of build off of that. But it was huge when I started looking at all those different modalities and the rules. So I narrowed it down to breast biopsy scheduling, and that's kind of what I'll talk about today. So I'm going to start over here with our patient. And so I went over and I observed quite a bit in central scheduling with Danielle and her team, who I have to say have a very, very challenging job when they go to schedule our patients. So I'm going to talk a little bit about that. So when a patient learns that they have to come in for a mammo, and there's something abnormal on that, then the order gets to central scheduling, but it can go a bunch of different ways. It gets faxed to email, the patient might call and say I have an order, the doctor may call and say I need to schedule Susie for a biopsy, and that comes to the central scheduler. Then they have to print the orders out, so they go into this fax to email queue. Sometimes they're walked down. So there's all these different methodologies for how the order actually gets to central scheduling. So once they receive the order, it goes in a stack of orders to be worked, or it can go into a wall file folder for tomorrow, or if they try to call the patient several times and they don't get an answer, then it goes in a file cabinet. And then if I call a few days later, they're going around to look to essentially track that order down, maybe going back into the queue. So you can see that this gets a little bit complicated. Then once they find the order, they retrieve it and do all the things I just said. Look in the stack, look in the wall folder, look in the file cabinet, look in the email queue. Then they have to try to find a time to actually schedule the patient. So once the radiologist makes a determination, yes, that patient needs a biopsy, whether it's a stereotactic biopsy or an ultrasound-guided biopsy, then they have to look to see which doctor recommended it, because the radiologist's preference is that the radiologist who read the study is the same radiologist to perform the biopsy. So they'll look to see which doctor recommended it. Is that the? Oh, over here? Okay, it sounded like it was right here. They will look for the first available appointment, and then they have to look to see if the radiologist is booked in another modality. So they might look and go, okay, I've got 10:30 next Monday, but is Dr. Maddie already scheduled in fluoro? So that's not an option for us. So there's all kind of like these hoops that they have to jump through in order to get the patient scheduled. If those won't work, then they have to go and manually look for another time. And there's also the central scheduling system's a little bit clunky. It will go out and look for that first available appointment, but there might be something open in a different slot that's earlier. So we've asked them to go back and see and attempt to see if they can find an earlier time. So they will manually look for another time. If they can find one, then they'll go and talk to the radiologist. They also have to contact other modalities if they have to move patients around. And then they call the patient. And then guess what can happen? The patient can go, well, Thursday at 2 o'clock doesn't work for me. And so we start right back over. So it's a pretty complicated process, which I say it's hard to have an appreciation for unless you really watch them attempt to do this. And so there's several storm clouds in this. So they're printing out orders, right? They're looking in multiple places when it's time to retrieve it. They have to find the order. The doctor who recommends the biopsy is generally the one that wants to perform it. We have all these scheduling rules. So when we started this, we had one time slot for breast biopsies to be done Monday through Friday. And that was it, which was a pretty limiting factor. And then the patient may not be available. They may say, well, no, that time doesn't work for me. So the storm cloud that we decided to work on was, I did some time tracking too, and this is our value quotient. So this is the time spent on the actual process over the actual time. So it ended up calculating to be 21.5%, meaning not a lot of value in there for the patient. It's a pretty tedious process. So on my A3, we wanted to work on breast biopsy scheduling, like reducing that delay from the time of the order to the time of the procedure. So the background measurement, patients experience a delay in timely breast biopsy scheduling resulting in delay of care, worry, concern for the patient, a lot of anxiety, and possible loss of procedures, right? We might be losing procedures to another facility because we can't get them in a timely manner. So for calendar year 2018 to current, so I just checked this data yesterday, we've done 23 stereotactic biopsies and 39 ultrasound guided biopsies. So this little diagram here is just our current state where they call the central scheduler. There's limited biopsy slots, and the patient goes, well, I can't wait 2 weeks to get in. I'm just going to go somewhere else. So the problem analysis, we really had some scheduling limitations. So the radiologist schedule, we have one radiologist who reads off-site. We often have weeks where we only have one radiologist physically here on site to help us with procedures. The radiologist who interprets the exam in which the biopsy is recommended is the one to perform the biopsy. And I will point out that central scheduling will ask the patient, you know, Dr. Maddie read your exam, Dr. Dingwall's available to do the biopsy, are you okay with that? And some patients will say yes, other patients will want to wait, and sometimes there's radiologist preference in terms of, you know, they really just want to do their own procedures. The other limitation is the limited breast biopsy slots, because we have to make sure that they don't conflict with other modalities like fluoro. So the radiologist may be booked in another modality or procedure, and so we also have to look at availability of other essential services like ultrasound, who will assist with those biopsies. So our target condition was to have patients scheduled for breast biopsies in 7 days or less, because when we initially started this, we had Tammy, Ron, Danielle, Tracy. There were several of us who were working on this. We were 14 days out sometimes on these breast biopsy procedures, sometimes even a little bit longer. And so what we want to happen is that, okay, I'm getting the time, but what we want to happen is for a patient to call and us to get them in less than 7 days and actually start moving that benchmark down. So some countermeasures that we looked at were for the central schedulers to go talk to the radiologist to approve for them to perform a biopsy if an exam was performed by another radiologist, and they agreed to do that. And to allow the biopsy to be scheduled any time of the day, as long as there was an opening and we had the resources. And so that's something that we've been working on too. So implementation plan, we identified key stakeholders. which was really that medical imaging access team that we had kind of already had formed, discuss the countermeasures, gather input, develop a plan, and roll it out. And you can see all of our dates here. So cost of implementation was really just staff time, us meeting, developing the plan, discussing it. Staff time to walk over to the radiologist and say, hey, are you willing to do this biopsy that another radiologist recommended? And staff time still having to check to see if those radiologists are booked in other modalities. So we tested that, we rolled out a pilot, removing the rules is really what we did, and just said, can we put it in as long as there's an opening? And I think for the most part, everybody's been pretty receptive to that, and it's worked pretty well. So, follow-up, we did pretty well. We rolled it out in about mid-January. In February, we were down to 5 days, and in April, we were down to 3. But I will say, when we just checked yesterday, we were back up to 10. And I think that's for a couple of reasons. We've had some ultrasound shorting stoppages, staffing shortages that have made it, we've really had to like reduce the schedule down to, we've had to slim it down. We've only had 2 ultrasound techs. We also lost a full-time radiologist that's here on site. We are recruiting, and we should have somebody come here in August. So we're hoping that this number will start to go back down. But Tracy, myself, Dr. Maddie, Danielle are all continuing, and Tracy and Tammy and Ron are all continuing to work on this. So as you can see, sometimes you make some progress, and sometimes you kind of fall back down. But we'll continue to work on that. My overall goal, and what I'd really like to see, is that if a patient comes in for a mammo and a biopsy is recommended, that we would get that patient in the same day. There's other facilities that are doing that. I think we can do that. We just have to have the staffing and work some other things out in order to make that happen. So that was pretty quick. Any questions? None?
Project was on intravesical chemotherapy in the urology clinic. And just to give you a background, we've always had urology in the community, but this is the first time we've had urology in our facility on site. So intravesical chemo, which is chemotherapy into the bladder through a Foley catheter, was new to us. So one of the first chemotherapies that our urologist ordered was something called BCG, and it's a live virus. Some might not really call it a chemotherapy aid because some live virus.
Isn't it a mycobacterium?
Whatever
Not a
she
virus,
says it is.
not a virus.
But it's something that has to be contained, and we have to have terminal cleaning afterwards, and it's like when the Joint Commission came, they wanted us to describe the process because it can be potentially not contagious. What do you want to call it?
No, I think it can be contagious.
Yeah.
It's
So-
certainly confusing
It is confusing.
if you found it in someone else's urine.
Yes. So it's not what is usually given in an oncology center, like we would have down here, just because of the way the rooms are set up. So it's given specifically for urology, and it's first-line therapy. It was the first time we had done it, and there's special ways of handling BCG is basically what I want to say. And again, the Joint Commission really followed our process because they wanted to make sure we were handling it correctly. So because it's considered a medication for a cancer, it needed to be done by oncology nurses. And oncology nurses go through special training, and 2 oncology nurses have to be part of every chemotherapy administration process. So that's important information for this particular situation. So the patient would come into the urology clinic. The physician would do tests and determine that it was bladder cancer, and they would decide that they wanted to provide BCG treatment for this patient. So that information goes from the physician, the patient, they talk about it, because there are other alternatives as well. then it goes to the nurse, then it goes, that information then goes from the nurse into the medical record as an order, goes to the pharmacist, goes to the oncology nurse, and then that information has to get to the housekeeper, because again, BCG is contained, or, BCG has properties that lend itself to needing what we call terminal cleaning, so that other people aren't exposed to it. So there's a lot of departments involved in this particular process. In addition to going into the EMR,
Yeah,
that information gets
okay.
faxed to medical oncology because they don't have the same EMRs. So, yeah, so there's a lot of backwards and forwards. Then the medical oncology nurses, so urology nurses fax the order in addition to putting in the computer, fax the order to medical oncology.
5,000.
Medical oncology looks at the fax, calls the nurses in urology to get more information about the patient. Then the medical oncology nurses call the patient to see if the patient can come at a certain time, because BCG has to be given at the end of the day
I'm happy to do it.
because of its exposure potential. So no one needs, we don't want anyone to use that room afterwards. So it's terminally cleaned by the housekeeping department. If medical oncology nurses don't get a hold of the patient, then they call the urology nurses to get a hold of the patient, and this goes back and forth until the patient is scheduled, which, like in Carrie's situation, then the patient might change their mind and come a different time. Well, in addition, we were only giving BCG on Tuesdays, Wednesdays, and Thursdays because that's when they had enough nurses there in medical oncology to double check the medication, go up to urology to double check the process, which is required when you give a chemotherapy agent. So these are all national guidelines we have to follow, so we were trying to make this process work. At one point, I got an email from medical oncology and said, this process is not working for us. It's really difficult to get the patients in and to make sure we can see our patients and take care of our patients and get this accomplished as well. So we thought of a lot of different options, and then I did my leave process. So I went to the department, followed them through the process from the time that the patient, I went to urology, walked with them through scheduling the patient with medical oncology, went down to medical oncology, followed that process, and then actually followed the patient through to actually giving the chemotherapy. And I've been a former chemo nurse, so I am very well versed on chemotherapy, and this process actually worked really well. The chemotherapy was given in 30 minutes exactly, which the book says it's supposed to be. So I came down to oncology with them, and I said, even though this part to me seems like it's might be a little bit disjointed, but your actual administering of chemotherapy was perfect. And they said, well, that's not really it. They said, this process actually works, which was a surprise. But while I was in medical oncology, one of the physicians called and said, I want to administer this other drug and the patient would like it at 10. Well, they had figured out the process of giving BCG at the end of the day, and it was working for housekeeping, pharmacy, medical oncology, everyone else. And they said, that's what the issue is. We cannot get these other chemotherapy agents just at any time of day. So it went from what I thought was a staffing issue to really being a problem of we were not able to provide anything but BCG here for patients with bladder cancer. And then what was happening is those patients were leaving and going elsewhere. Now surgery is another alternative, but that's not always the best alternative. And if they weren't able to receive those other forms of chemotherapy, they would have to go somewhere else. So we were losing patients to other facilities when we really had the technology and the capabilities to do that here. So the reason we couldn't do them here is we didn't have enough nurses who were chemo certified. And to be chemo certified, you have to go through an arduous course. You have to be checked out by chemo nurses, and even after that, 2 nurses, even a nurse double checking the medication has to go through an oncology course. So the plan then was to get nurses hired. I looked around and we assessed all the different departments to see what nurses could be available to learn how to provide chemotherapy. And the best option we found, or I thought, was to hire a part-time nurse for the urology clinic. I wanted 2 part-time nurses because you always have to have that double check. And then nurses from medical oncology wouldn't have to be there at all to provide this chemotherapy. So we were able to find one nurse who was willing to learn to give chemo in the urology clinic. She finished her oncology certification in the middle of April, did her hands-on practicum with the oncology nurses, and finished that on May 8th. And by May 28th, the medical oncology nurses and this nurse felt like she was able to confidently give chemotherapy on her own. Now, physicians can double check the chemotherapy and go through that process too. So sometimes she's had to rely on the physicians double checking the chemotherapy. But in the interim, that they've been able to find another nurse from oncology to run up and double check it and then come back down again. So the implementation plan was to find 2 nurses. I was able to find one. It is working so far, but in order to even get that process outlined, it was Leslie and me and the Aaron's and oncology and pharmacy who all had to work together to make sure that this was going to be possible. So there's a lot more moving pieces to it than one would think. So the cost of implementation is really hiring and the chemotherapy courses, and then the nurses having to precept this nurse in urology. The timelines were for in December to hire 2 part-time nurses. We weren't able to do that till January, but we were able to get that accomplished. Everything was about a month delayed, but in the end, by May 28th, the urology nurses, medical oncology nurses, and then specifically the nurse administering chemo in urology said we can safely say that we are able to administer all forms of chemo except for experimental in the oncology clinic, or in the urology clinic. So as for right now, we're not turning any patients away or to another facility for chemotherapy in urology.
Nice.
Yes, it turned out to be very nice, but what I thought was the issue was really, I thought, this is always the issue, but it didn't turn out to be
The
that at all.
vaccine wasn't the issue?
No, and that's really kind of what the cool part of lean is. You know, my brain went automatically, it's staffing. Well, when you really think it was, but when you drill a little deeper, we could not provide all the types of care that we could give to patients here that we have the ability to do. Cost benefit was really difficult because it's all based on reimbursement and the cost of surgery, but lo and behold, there is an article out there called The Economics of Bladder Cancer in the United States, the Cost and Consideration for Caring for this Disease. And it actually went into all of that. So they talked about cost of radical cystectomy if you couldn't do chemo, and they used 12 patients. But the benefits of being able to give all forms of chemotherapy to the organization was a potential cost savings for 12 patients of $512,000.
Wow.
So that's pretty significant.
Christy, I think it's important to point out too that when Joint Commission came through in 2007, and we had some things we had to work on relative to this process, that they said a lot of people just kind of wash their hands of it and
Yeah.
say, we're not going to do it anymore. And so I think the fact that we could consider the patient and try to figure out the best thing for the patient is really important.
And I was worried too that the patients, because we could only get BCG Tuesday, Wednesday, and Thursday at that point, because of the terminal cleaning and the nurses, needing 2 nurses in the oncology to be present, was going to be a problem for the patient. And the patients really weren't that upset about it. They knew when they were explained why it had to be at the end of the day and a little bit more about the BCG, they were fine with it. But now we're able to offer it at the end of the day all the time.
Do you have any sense of how many patients stay in the community now that, several, that you can offer the extended chemotherapy? Do you have a number in mind?
I don't, but that's what she's tracking from this point on, is all the types and numbers of patients who are able to receive this type of chemotherapy and don't go to the Huntsman for chemo.
Because that'd be really your real true cost benefit is.
And I could go backwards and look to see how many patients have been sent to Huntsman for intravesical chemo.
That's wonderful.
And we didn't want to do it in the oncology clinic because there were too many other patients in the vicinity with all the, with all of these other agents. And then in case the Foley catheter was hard to insert, we wanted the urologist to be readily available. So we really wanted to keep it in the urology clinic, so we were able to do that.
So now you have chemo-certified urology nurses?
One chemo-certified nurse at this time, so we'll evaluate that, and if we need more nurses, then we'll go through the same process and get that nurse certified as well.
Nice.
That's
Patient satisfied.
It really is, it feels very good to be